We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question number 1. A 5-year-old child was admitted to the hospital with a history of prolapsing rectal mass and painless rectal bleeding. The histopathological image of the mass is shown below. What is the most likely diagnosis? Your option are. And the correct answer is juvenile polyp. Here is the explanation.
Juvenile rectal polyp. Please remember, there is a very easy way of learning this because juvenile will tell me that the age is going to be juvenile, that is less than 5 years. The location is there in the polyp itself. What is the most common location? It is most commonly seen in the rectum. If something is most commonly seen in the rectum, then the clinical feature is also clear to me. This means the child will have bleeding PR, and that is exactly how the question came in NEET PG 2019. They gave you a question of a 5-year-old child with bleeding PR. Tell me one thing, if it would have been a 70-year-old person, 70, 80-year-old person with bleeding PR, I could have thought of cancers, I could have thought of piles, hemorrhoids. But in a 5-year-old, can I think of cancer? No. Can I think of piles or hemorrhoids? No. In 5-year-old with bleeding PR, the first thing that I will think of is a juvenile rectal polyp. Now, please remember, this could either be sporadic, single polyp is seen, no genetic problem, nothing, just a single polyp is seen, khatam. Or it could be syndromic, as a part of some syndrome. Multiple polyps are seen, mutations are seen. And what are those mutations? There can be SMAD2 mutations, there can be SMAD4 mutations, there can be BMPR1A mutations. How will I learn so many of these? Please remember, everything about juvenile rectal polyp is juvenile. The age is also going to be less than 5, and all the numbers that you are using in the genes are also going to be less than 5. So age less than 5 and the numbers SMAD2, SMAD4, BMPR1A. So all the options with less than 5 genes, those are the ones you'll put under juvenile rectal polyp. But all said and done, so many mutations are occurring, so many polyps are occurring. Is it just going to be just polyp in the rectum and that's it? Is there any extra intestinal manifestations also that you can see? Yes, we can see digital clubbing. Digital clubbing can be noted, and vascular malformations can also be seen. So it is just not associated with just a polyp in the rectum. There are extra intestinal manifestations, especially getting a question on digital clubbing is much expected. So now if you want to look at this under the microscope, and actually let me tell you, the microscope is quite a formality. This is just a time-waste photo. So first I'll teach you. What do you see? You see these big glands. Big, round, weird glands. What do they call them? They call them cystically dilated glands. Now, be very honest. If without any history, I would have given you this slide in the paper without telling you anything that from which chapter this has come. Be very honest with your hand on your heart. Tell me, could you have identified this as a juvenile rectal polyp? I also could do that after many years of histopathology. As a NEET PG aspirant or as an FMG student who has hardly seen any slides, you don't have the expertise of a resident, do you think you could have identified it? I think 99% of you will say no. An examiner is not going to make you do that. So whenever this question came, and this question came in the NEET PG 2019, and let me tell you, it came as a 5-year-old child or a 5-year-old boy with bleeding PR. That is how the question came, and this picture was given. So could you have correlated? Yeah, then anyone can give the answer. So don't worry if this picture will never ever come like a spotter image to you. No, it will always come with a corresponding history. That is the first thing, that is juvenile rectal polyp.
Question 2. A 56-year-old man presents with dragging pain in the abdomen. On examination, there is massive splenomegaly. A peripheral smear shows leukocytes with increased myelocytes, metamyelocytes, and basophils. Which of the following translocations is seen in this condition? Your option are. And the correct answer is T9, 22. Here is the explanation.
When I talk about CML, chronic myeloid leukemia, there's a very famous genetics that everyone knows, and that is translocation 922, right? The Philadelphia. So let us draw it out. Here you have chromosome 9 in front of you, and here we have chromosome number 22. And let's draw the normal. What does normal chromosome 9 have? Normal chromosome 9 has ABL, and normal chromosome 22 has BCR. But now I'm saying there's a translocation, means this ABL has gone and sat over here. So here you have the ABL and here you have the BCR. Has there been a BCR-ABL fusion? Because of this BCR-ABL fusion, there is an increase in which activity? There's an increase in the tyrosine kinase activity, and that is going to result in CML.
Question number 3. A patient presents with midline swelling in the neck. A biopsy revealing often Annie's eye nuclei is shown in the image below. What is the diagnosis? Your option are. And the correct answer is papillary carcinoma. Here is the explanation.
For papillary, it's associated with radiation, with Hashimoto's, with thyroglossal cyst. What is the most common mutation? The most common is BRAF. Other than that, red PTC is also seen, others are also seen, but BRAF is most common. What are the findings that you notice? The first finding in front of you, this is the very famous orphan Annie eye nucleus. Yes. What do you see over here? I can see an inclusion, intranuclear inclusion. And what do I see over here? The coffee bean appearance coming to a body. What is this body? The very famous Samoma body is also noted. And finally, what is the finding that I see on an FNAC? On FNAC, I see the very famous chewing gum colloid. So chewing gum colloid is also something that we notice on FNAC. I hope that is okay with everyone.
Question number 4. A 65-year-old female patient is diagnosed with pure red cell aplasia and mediastinal mass. Which of the following is a likely cause? Your option are. And the correct answer is thymoma. Here is the explanation.
Gravis and pure red cell aplasia. Why am I putting them together? Because they are the only few questions that I get on a thymus gland tumor. That is thymoma. Remember, thymoma shows you which neurological problem? Myasthenia gravis. And which bone marrow problem? Pure red cell aplasia. What is the meaning of this? Red cell, red blood cells, aplasia not being formed. Red blood cells will not be formed. So myasthenia gravis and pure red cell aplasia are features of thymoma.
Question number 5. An elderly patient presents with anemia and hemoglobinuria. Investigations reveal increased bilirubin and lactate dehydrogenase. The peripheral smear image is given below. Which of the following is associated with this? Your option are. And the correct answer is mechanical second heart valve. Here is the explanation.
So macroangiopathic basically means there is some big blood vessel involved. So macroangiopathic hemolytic anemia, and then there is a smaller one which is referred to as microangiopathic hemolytic anemias, where I'll be talking about the smaller blood vessels. But why about hemolytic anemias am I talking about in this topic of platelet? Have you wondered why am I doing that? Because now I'll be telling you the reason. When I say macroangiopathic, macro means a big blood vessel, which is the biggest blood chamber of our heart, of our body. The biggest blood chamber of our body is the heart. So now, for example, in the heart, if there is a prosthetic heart valve, that has been put up, now what do you think? Imagine, compare, what is a prosthetic heart valve? It's a kind of an implant which has been taken from another species and put into the human. So it's not similar, exactly carbon copy nahi hai. It's not an exact similar thing of a human valve. Very similar, but not exactly the same. So don't you feel that there can be some collision if this is a heart valve and some RBCs are going, they will collide and break? Yes. So that can result in macroangiopathic hemolytic anemia, means the RBCs can break. That is referred to as fragmented RBCs. And do we know what are fragmented RBCs known as? We know from our discussion way back in hemolytic anemias, fragmented RBCs are referred to as schistocytes. So this is how the picture of a schistocyte looks like. Look at all the RBCs. They're all broken into random shapes. You can call them random, porcupine shape, helmet shape. So many of these shapes are possible. That is nothing but schistocytes. They are basically broken into different aspects. That is what you need to know.
Question number 6. Cowden syndrome is associated with mutations in. Your option are. And the correct answer is PTEN. Here is the explanation.
The next gene is the PTEN gene. This is another one of my favorite ones because it has a very nice rhyme to it. So I'm going to talk about that rhyme. Listen to this very carefully. First, let me tell you the mnemonic. The mnemonic is P10 means chromosome number 10, and the syndrome is going to be cow-den. Sounds easy? 10-10-10. So what is the name of the gene? The name of the gene is P10. The number of the chromosome on which it is present is chromosome 10, and the syndrome which it causes is cow-den.
Question number 7. A child is presenting with palpable blanching purpura, abdominal pain, and pain in the knee joint. Urine examination showed hematuria and proteinuria. What is the most likely diagnosis? Your option are, and the correct answer is Henoch-Schönlein purpura. Here is the explanation.
What is HSP? Henoch-Schönlein purpura. So let us quickly read about this disease, and then we'll come back to the other category, that is pauci-immune. What is Henoch-Schönlein purpura, which is very famously written as H, S and P? So first and foremost, if I read the word purpura, what comes to my mind? Some kind of rash, reddish color, like in dengue fever. Dengue fever patients have red color rash, na? That is a purpuric rash. So whenever I read purpuric rash, one thing comes to my mind is that something has happened to the platelet count. What has happened to the platelet count? Like what happens in dengue fever? Does the platelet count go down? Yes, that is why patient has rash. But over here, this is nothing to do with the platelet count. Means, is the platelet count going to be low? No, in fact, the platelet count is totally normal. And for that matter, platelet count can sometimes be increased also, but it's never going to be low. So the point is that this is known as a non-thrombocytopenic purpura. It has nothing to do with the low platelet count. Non-thrombocytopenic purpura. And let me tell you one more thing, that if it's not because of platelet, then what is it because of? What is the cause? It is an antibody that is known as IgA. It is IgA mediated. So you know what? If this, for example, is a blood vessel, who is going to go and sit in that blood vessel? IgA is going to go. This antibody IgA will go and sit in the blood vessel. That is why this problem is happening. So let me ask you the clinical features, and it's very, very interesting. Instead of calling it Henoch-Schönlein purpura, from today onwards, we will call it Henoch-Schönlein purpura. Why do I say that? Because as soon as you write the word purpura, you will now see the 4 organs that are affected. So first one, P for obviously the name only. There is going to be a purpuric rash. There is a purpuric rash, reddish color rash, which is usually going to be on the lower limbs. Next, these patients have joint pain. That is, joint pain is written as what? Joint pain is written as arthralgia. Next, these patients have abdominal pain. So there is abdominal involvement also. There is abdominal pain. And lastly, there is involvement of the kidney. There is renal involvement. And you know how? Blood comes out into the urine. Blood comes out, hematuria. In fact, let me tell you, renal involvement is the most common organ involvement in Henoch-Schönlein purpura. So this is such a favorite question, not only because it's commonly seen, but also because it's a favorite with the examiners. And you know why? Pediatrics ka question hai. Means Henoch-Schönlein purpura is going to occur in children.
Question number 8. All of the following statements are true regarding neutrophil extracellular trapping, NET, except your option are, and the correct answer is mitochondrial DNA is seen. Here is the explanation.
It has given the entire nucleus. Can someone survive without a nucleus? Can a cell survive without its nucleus? No. Can I say at the end of this entire journey, the soldier is going to die, is going to give his life for you. So the neutrophil is going to die out. So it's truly a soldier because it has saved your life and it has given up his life for you. Can I call this a beneficial suicide? And that is the next question that they put up to you. What is the other name of NETs? NETs is a beneficial suicide. Always remember, NETs is that soldier who wanted to protect you. He wanted to kill your bacteria, virus, parasite. So he gave up his nucleus. He gave up his life. That is known as a beneficial suicide. And do you know who is going to help in all of this? There's a question that has come in the previous year JIPMER papers. Which amino acid helps in NETs? Which amino acid helps in NETs? And the answer is arginine. Arginine helps in NETs. Very, very important question. Next, can there be any Complication or side effect because of this? Can you tell me? Any complication? Think logically. All of us, in all our normal cells, nucleus is supposed to be inside. But in this soldier, the nucleus has been sent outside. Only the nucleus is not going. A lot of nuclear antigens are also suddenly going outside. I was not used to seeing them. For me, the antigens always used to be here inside. Suddenly, I'm seeing all the antigens have come out over here, that is outside. Will I suddenly start making antibodies? I have never seen these antigens before. I will start making antibodies against it. So can I say one of the complication is anti-nuclear antibodies will be formed. Anti-nuclear antibodies are going to be formed. And is this reminding you of some autoimmune disorder? Yes, this is going to result in SLE. So that is what they saw. That a lot of people in whom NETs was going on, there was a complication that they were showing you formation of SLE. These are some very, very important questions that I have written over here. First question. What is the cell that is involved? Neutrophil. Where is the site of killing? What is the site of killing? Extracellular. What is the other name of this condition? This is known as a soldier, a beneficial suicide. That's the next name. When do you use this process? When there is sepsis. Which amino acid helps in it? Arginine. Is there any side effect or complication? It is associated with SLE. Let me show you a real-time photo. This is an electron microscopic picture which all of you are going to divide into two parts, because in the first part I'll give you orientation. Over here, the green color that I'm seeing is going to be the cytoplasm, and the orange color that I'm seeing is going to be the nucleus. There is a cytoplasm and there is a nucleus. Sounding logical? Okay. When I go here, I see the same green color. The same green color is the cytoplasm that we had above. But that orange color is missing. Where is that orange color? That all of the orange color is going to be outside. Can I say the nucleus has gone outside extracellularly? That is why we are saying that is there is neutrophil extracellular traps. Whenever you see the nucleus is roaming around outside, there is a neutrophil extracellular trap. So before I end this, tell me some quick points. If I say which of these shows you intracellular versus extracellular killing, it's obvious. Neutrophil extracellular traps shows you extracellular killing. Phagocytosis was putting the food into your mouth, so it shows you intracellular killing. You've understood the difference between both of them. All the questions of NETs are done, because now I'm going to tell you a phenomenon of no killing. I'm just done with so much of killing. I have done killing inside the cells. I have done killing outside the cells. Now I want to forget killing. No killing happening, but something called cell-in-cell phenomena. So remember, cell within cell. Cell within cell phenomena is known as emperipolesis, but remember the rule now, no one is killing. Lot of killing has been done. Let's maintain peace. Cell within cell appearance, but there is no killing that is going to occur. That is known as emperipolesis. So what will you have? Have a look at this. You will have a big cell like this, and that will have a tiny cell inside it. A big cell has just taken and kept a tiny cell. For example, you see those very small kids, the 1 year, 2 year old kids, you put food in their mouth, they keep food in their mouth on one side and then they don't chew it, they don't digest it. It's something like that. After some time, they will spit it out. That is emperipolesis. Emperipolesis is that 1 or 2 year old kid who puts food in his mouth. You keep telling him to chew and to swallow it. He will not. He will keep the food over here. After some time, he will just spit that food out. So cell within cell is there, and after some time that cell will come out. There is no killing that has happening. So they ask you that where do you see this cell in cell appearance? You see it in conditions called as MARC. Means the first one is MDS-MPN, myelodysplastic syndrome or myeloproliferative neoplasms, very important diseases in hematology. Next comes the previous year question, autoimmune hepatitis. Autoimmune hepatitis is going to show you emperipolesis. Next, Rosai-Dorfman syndrome. Rosai-Dorfman syndrome, RDD, is a lymph node disorder. So, Rosai-Dorfman disease, RDD, lymph node disorder. And finally, the C is going to be for CLL. All of these show you that there will be a big cell which has kept a small cell inside it but no killing. That is known as emperipolesis.
Question number 9. An African child is found to have a mass in the jaw. A biopsy of the mass was done, and it appears as shown in the image below. The child also had a translocation, T8-14. What is the probable diagnosis? Your options are, and the correct answer is Burkitt lymphoma. Here is the explanation.
The genetics is very simple. It's going to be 8 with some kind of an even number. Remember I told you Burkitt's begins with an 8 or B. So B looks like an 8, or many people learn it as Burkitt instead of Burkitt's. Many people also remember it as Burkitt. That's also a way of learning it. So B for 8 or Burkitt, whatever suits you. 8 with an even number. So either you'll type out 8 and 14, or you'll have 8 and 22, or you'll have 2 and 8. So some 8 and even number is going to be there. And 8 signifies C-MYC amplification. That is what is important. So C-MYC is amplified. Please remember that this is very commonly associated with tumor lysis syndrome. Very famous question in medicine. The lymphoma associated with tumor lysis syndrome is Burkitt's lymphoma. It has certain types. What are the types? Firstly, it could be endemic. And you know, where is it endemic? It is endemic in Africa. But endemic to what? Endemic means that all the cases are associated with Epstein-Barr virus. So, you know, this usually presents, I'll tell you a history. They will always give you an African child with a jaw swelling. I'll show you a picture also in a while. African child with a jaw swelling. So Africa, because this is EBV is endemic in Africa. EBV is endemic in Africa. So all the cases will have EBV positivity. Child, I've always learned C-MYC. C-MYC is occurring over here because C for child. So this is a childhood lymphoma, and there is a jaw swelling. So that is the endemic form. Then there comes a non-endemic or a sporadic form. And then there is a form which is always seen with HIV, that is an immunodeficiency form. There are 3 types of Burkitt's lymphoma. Endemic one you've done, the Africa one. The second one is sporadic, and the third one is immunodeficiency. In sporadic form, remember, EBV can be present. Approximately EBV is present in 20 to 30% of the cases. Whereas in immunodeficiency, EBV is seen in 30 to 50% of the cases. EBV association is still in both of these, but it's not 100% like the endemic one. EBV is there in these also, but they ask you the site. In sporadic, remember it is going to be the ileocecal junction or the GI tract which is commonly present. So they will give you the history of a child with an ileocecal mass. They will give you the history of a child with an ileocecal mass. GIT involvement will be there. And for immunodeficiency, they can give you any site on this planet. Imagine, I've seen a case of once, a very, very rare case, hardly documented in literature. I've seen a HIV positive patient with the Burkitt's lymphoma of the eye presenting as proptosis. Very, very rare. Burkitt's lymphoma of kidney has been published so many times in HIV positive patients. So yes, that makes it quite rare sites, or any site of the body can be affected if the patient is HIV positive, immunodeficient. If it is sporadic, it will be a GIT mass, but when it is endemic, the most common, African child jaw swelling. So have a look at that African child. This child is a celebrity because every GT, every subject-wise test, every exam, everyone has this African child with a jaw swelling. But now you know the reason of why have I called it Africa. So when I say African child with a jaw swelling, Africa's significance lies in Epstein-Barr virus being present in 100% of the cases. So now when you do an FNAC from the lymph node, so for example, there's a big jaw lesion over here, I put a needle inside it, I did an FNAC and then I did a biopsy. So what are the differences that I'll see? Have you seen this picture elsewhere in this chapter only? There are vacuolations present, and I'll repeat that story. The vacuolations are oil, red, O, positive. Where did we study? Did we study the similarity in some ALL? Which ALL? L1, L2, L3. And that time also I told you L3 and Burkitt's are counterparts. L3 was also oil red O positive. Burkitt's is also oil red O positive. They're almost like counterparts. Coming to the next, that is biopsy. The biopsy shows you the famous starry sky appearance. So the sky, the background of this edition of PrepLadder is anyway, the background is like the sky. But now we have what we are teaching teaching you are the twinkling stars. That is what we are teaching you. So you can see the black background with twinkling stars. So what is the black background? Black background is all of these blue color, all these blue color cells. So do you know that when you are talking about the starry sky appearance, they ask you what is the stars and what is the sky. So this black background sounds pretty dark, means the black background is the tumor cells. The sky part is the tumor cells, and what is shining? Like I told you, whatever we are teaching you, high yielding points, those are going to be the stars, the ray of hopes. That is not a tumor. That is the nice part. Those are referred to as tingible body macrophages. Those are referred to as tingible body macrophages. Let us mark it out. Have a look at this, guys. Look at the background. The background is all dark. The background is all dark, so that's all the tumor. But if I look at some white cells in between, can we all see there are some whitish cells? If you want, we can zoom in also. There are some twinkling stars in between, and these are nothing but macrophages. They have eaten up some cells. They are tingible body macrophages.
Question number 10. A pediatric patient arrived at the hospital with cola-colored urine, high blood pressure, and swelling around the eyes. Laboratory tests were conducted, revealing a creatinine level of 2.5 mg per deciliter. After commencing the treatment, the patient exhibited no signs of improvement over a period of 3 weeks. Furthermore, their creatinine levels rose to 4.5 mg per deciliter. Consequently, which of the below electron microscopic observations is expected in this patient? Your option are, and the correct answer is subepithelial deposits. Here is the explanation.
Post streptococcal glomerulonephritis. So obviously the first question coming to your mind is, what causes it? Streptococcus causes it. Streptococcus causes it. So which streptococcus am I talking about? It is streptococcal pyogenes, and streptococcal pyogenes belongs to which particular family? Asking you microbiology. It is group A, beta hemolytic streptococcus. It is group A, beta hemolytic streptococcus variety. So they ask you what strains. The strains are going to be 12, 4 and 1 in the same order. The strains are going to be 12, 4 and 1, and let me tell you, from this only I can derive the incubation period, because from 12, 4 and 1, if you take the last two numbers, the incubation period is going to be 1 to 4 weeks. So repeating once again, post-streptococcal means streptococcal pyogenes. Strains are going to be 12, 4, 1. Take these two numbers out of it. It's going to be 1 to 4 weeks as the incubation period. I'm missing out on one question. What is it also known as? That I'll tell you in a short while, because I'll explain some microscopic features. You will automatically know the name. But you've understood the strains. You've understood the incubation period. Can I now teach you what are the clinical features? Yes. Going forward, what are the clinical features? So you have to put a little bit of common sense. Streptococcus, don't think of big things like kidney. Think of something very basic. What does streptococcus cause in a general population? Sore throat, pharyngitis. So the first thing that my patient is going to have will always be a sore throat. Now, after a sore throat, some timeline later, which you guys are going to tell me, some timeline later, there is a patient who now comes to you with cola color urine. Why am I writing cola color urine? Because I know that PSGN is a nephritic syndrome, and anything with a nephritic syndrome means, will there be hematuria? Yes, there is going to be hematuria. But why did I tell you that you will tell me the timeline? Because go back to your immunology chapter, and PSGN is which hypersensitivity? It is hypersensitivity type 3, and I had given you a hint over there and made you practice a question in immunology that any type 3 hypersensitivity reaction takes how many days to manifest? It takes 10 to 14 days to manifest. In simple words, it is 2 weeks. In very simple words, 10 to 14 days. So whenever they give you a history of a pediatric, of a child, PSGN for pediatric, the child had sore throat, and 2 weeks later, the mother is saying that my child is passing blood in the urine, cola color urine, coffee color urine, these kind of brownish colors are used. You are dealing with PSGN. What are you going to do next? You are going to go in for a blood test. Whenever some turn comes to me with sore throat, fever, blood test is what we do. So what am I going to get in a blood test? Think logically. First think logically, because you're thinking in terms of streptococcus. So what do you have to know out here? You will do antibodies for streptococcus. So firstly, I would do some antibody testing. I know the antibody which is coming to your mind for streptococcus that you do is anti-streptolysin O. Yes, you do that for any streptococcus patient, anti-streptolysin O. However, what is better or what is preferred over here is anti-DNase B. Please remember, anti-DNase B is the preferred antibody detection over here. That's the first set of blood tests that you'll do. What is the second test of blood test you'll do? Remember, these patients show you a very, very, very important concept called transient hypocomplementemia. They show you transient hypocomplementemia, which means hypo means less, complement proteins are going to be decreased, especially C3 is decreased. All of them go down, especially C3 is decreased, and this happens very transiently, only for a few weeks. After that, they will automatically come back to normal. Basically, the concept is that till the time the streptococcus antigen antibody are roaming around in the blood, every antigen antibody, I know for a fact streptococcus is an antigen. Yes, it's a bacteria, it's an antigen. I will make antibodies against it. So basically, I am making antigen antibodies complex. I am making an immune complex. Will an immune complex always go and activate my complement? Yes, it will always go and activate the complement. As a result, see, complement is being activated. So obviously, the complement levels will go down. Once the complement levels go down, please remember that the patient is going to show you less of C3. Now, there's one extra edge point that I want to tell you. Although all the complement levels go down, but for reasons unknown, C4 levels tend to remain normal. Again, like I said, the exact reason for this is not known, but C4 levels tend to remain normal. Yes, the most important is that because so much of complement is being activated, the complement levels will go down. Now, once the antigen will go away, after some time the streptococcus will be cleared off. Once the antigen will go away, the immune complexes are going to be removed. Then there is no activation of complement. This means everything will come back to normal. That is why I said it's transient. For some time, the complement levels go down. After some time, they are back to normal. I hope everyone's okay with it. Yes, so these are the blood tests, and this word is, like I said, very, very, very important. Okay, moving forward, now let's go on to the real pathology part. You already know how it looks grossly. Guys, did I not teach you in the beginning part these pictures? What are these pictures? The very famous flea-bitten kidney. And I gave you a mnemonic also for flea-bitten kidney, and that was We Hate PSM. Remember, in We Hate PSM, I told you that P was for post-streptococcal glomerulonephritis. And you can see these two pictures. You can see the red color ... flea bitten. You can see the red color ... flea bitten. Let me tell you, this is the same picture that came in the previous NEET exam. So remember this, guys. The red color ... is what will make the flea bitten appearance. So that is the gross finding. Now we move on to light microscopy. Light microscopy means regular pink and blue stuff. Thankfully, and I know all of you will be very, very happy knowing this. Thankfully, you don't have to learn any picture for light microscopy, but you have to learn what is happening. And here I can tell you with light microscopy, what is the other name of post-streptococcal glomerulonephritis. So firstly, they said because it's, many people started asking that, is this entire disease only because of streptococcus? I mean, no other bacteria can cause it. No. They said rarely other bacteria like staph and others could also cause it. Very rare. So then they said that, when others can also cause it, why have you named it only after streptococcus? They said, let's call it PIGN. Means post some kind of infectious. So post-infectious glomerulonephritis was another name given because they thought that other infections can also rarely cause it. Next, when they saw the microscopy, they realized that there is a lot of proliferation of cells that is going to happen. They then called it acute proliferative glomerulonephritis. They called it acute proliferative. Now, what proliferation is happening? So please remember, there's an increase, whatever you know inside a glomerulus, increase all of that. What is the lining of the blood vessels? Endothelial cells. Increase it, guys. There's an increase in the endothelial cells. What are the macrophages of the kidney known as? Come on, think. I taught you in the first part. Macrophages of the kidney, mesangial cells. So there's an increase in the mesangial cells. Then think logically that there is so much of infection, streptococcus or some kind of infection. So inflammatory cells will will also come. There's going to be an increase in the neutrophils. There's going to be an increase in the macrophages or mesangial cells. That means overall the kidney is what? Hypocellular or hypercellular? So many cells. The kidney becomes hypercellular. There is a hypercellular glomerulus that is noted, as a result of which, please remember, we call it too much of proliferation. We call it acute proliferative glomerulonephritis. Having said that, you're not going to get a picture, but this description of hypercellularity and too much of proliferation is very, very important. Now, what are you going to get a picture for are these two. What do you see on immunofluorescence and electron microscopy? Guys, you need to understand, at the end of the day, it's an antigen-antibody interaction. Antigen-antibody basically means some kind of an immune complex. And when we are dealing with an immune complex, where will that immune complex go and sit? You try to analyze. This is an electron microscopic picture. All of you are very well versed with this orientation that I made you do in the first part. Can you all visualize what are these structures known as? What were these? These were feet, right? Everyone remembers they were epithelial cells. They were the visceral epithelial cells or the foot processes. Now suddenly, do you see one of that foot has become like a mountain? A big mountain. Why has it become like a big mountain? Because there is a deposit that is present over here below the epithelium, below the podocyte or foot process. So I call it subepithelial humps. We call it subepithelial humps. That is what you see on electron microscopy. We see subepithelial humps on electron microscopy. And now the question is that, is the immune complex only going to sit here? No, if you increase the immune complexes, they will sit below in the membrane also, they will sit in the endothelium also, they will sit everywhere. But what is the characteristic? Subepithelial hump.
Question number 11. A patient underwent a cystoscopy, which showed multiple yellow-white plaques in the trigone of the bladder. The histopathology image is given below. What is the diagnosis? Your option are. And the correct answer is malakoplakia. Here is the explanation.
This is a urinary bladder, and when the clinician was doing a cystoscopy and looking at the urinary bladder, clinician found that there were many yellow-white plaques present on the mucosa. There were very yellow-white mucosal plaques that were present. So, whenever you see whitish areas in the urinary bladder, the clinician always gets worried that is it cancer? Yes, this tends to mimic cancer. So how will you rule out cancer? You will have to do a biopsy. Fine. So this disease which you call as malakoplakia, this very commonly mimics cancer. So you decided, okay, I don't want to be scared that is it cancer, is it not cancer? I don't want to be in that doubt. Let me do a biopsy. So I did a biopsy from these mucosal areas and I found this. What is it? It's looking like any other pink and blue slide. But if I look very, very carefully, I can see some blue color bodies. And this one is looking almost like a samoma body going round and round. And there are many blue color bodies and I want you to look at them carefully. I want you to do the real work of a pathologist. It is looking as if this is a pink color cell and there are two blue color bodies inside it. What is this happening over here? It looks as if this is an entire cell. There are two blue color bodies inside it. So now I'll explain this to you. The entire cell that you guys are seeing, the first blue color thing that you have inside it is the nucleus of the cell. So the big cell that you have with the nucleus, it's just the cell. These are basically macrophages. These are basically macrophages and every cell will have a nucleus. So this is the nucleus of a macrophage. But what is it eating up? It had tried to eat up a bacteria. What is malakoplakia? Coming to that. Malakoplakia, for example, someone gets infected with E. coli. Let's talk about the most important infection, that is E. coli infection. Who is going to come and eat the E. coli? Macrophage will come. How does macrophage eat? Going back to your basic, how does macrophage eat? By, yes, phagocytosis, phagolysosome formation. But malakoplakia says that my defect is that there is a phagocytosis defect. There is going to be a phagolysosome defect that is going to be there. This means this is the macrophage. This definitely engulfed the E. coli, but could it kill it? If it has a phagolysosome defect, can it kill it? No, it cannot. What starts getting deposited around around it, calcium starts getting. So the other blue color, dark blue color dot that you guys are seeing, that is nothing but calcium. And you know what have they named? Now basically what I'm seeing is there's a macrophage that wanted to eat the E. coli, but it could not because uska phagocytosis is not working. So a lot of calcium got deposited around the E. coli. This calcium is known, only the calcium is known as the Michaelis-Guttman bodies. The calcium is known as Michaelis-Guttman bodies. And do you know what this entire cell is known as? Means the cell with the calcium. This is known as the von Hansmann cell, because scientist who discovered it needs credit. So von Hansmann cell. Repeating once again, if they ask you only the name of this calcium body, to remember M for M, that is the most famous question. Michaelis-Guttman bodies are seen in Malakoplakia. Michaelis has a K sound, Malakoplakia has a K sound, the composition is a K sound, that is calcium. Yaad rahega? Michaelis, repeating once again, Michaelis is seen in Malakoplakia, M for M. Malakoplakia has a K sound, Michaelis has a K sound, calcium has a K sound. So they are all the same. And what is that entire cell known as, which has eaten up the Michaelis-Guttman body? The entire cell is the scientist, that is the von Hansmann cell. So now imagine this clinician, while after looking at this, was very worried, cancer to nahi hai, is it a cancer or not? But when you did a biopsy, you could tell him that no, Michaelis-Guttman bodies are seen, this is a phagocytosis defect, this is not a cancer, so do not be worried.
Question number 12. A 34-year-old female patient presented to the outpatient department with migratory arthritis, and examination revealed a pansystolic murmur. An echocardiography was performed, which was suggestive of mitral regurgitation. A biopsy specimen was obtained, and the image is provided below. What is the most likely lesion shown in the histopathology slide? Your options are, and the correct answer is Aschoff's bodies. Here is the explanation.
The most characteristic lesion of rheumatic heart disease. I'm assuming you've heard of it because it's so famous. The most characteristic lesion is Aschoff bodies. Either you call it Aschoff bodies or you call it Aschoff nodules. That's not a concern, but it's the most characteristic lesion. So first question that will come to your mind is, where do you see these bodies? Remember, they are seen, question number 1, they are seen in all the layers. Matlab, they are seen in pericardium, they are seen also in the myocardium, they are seen also in the endocardium, they are seen in all the layers of the heart. But examiners never happy with these all kind of questions. Examiner will always have that thing of asking you, no, where are maximum found? So remember, maximum Aschoff nodules are found in the myocardium. M for M, that is how I have learnt it. M for M, maximum Aschoff nodules in the myocardium. Fine. Your next question is, what are Aschoff nodules? So let's draw it out now, then we'll understand it best. So you know, in the center of the Aschoff nodule, we have a very famous necrosis. I have told you that necrosis way back in your first chapter. In the center, we have something known as fibrinoid necrosis. In the center, we have fibrinoid necrosis. Surrounding it, we have some cells, and those cells are going to be very interesting. See, I'm drawing two types of cells, but they're not two types. In one cell, I'm making this design, okay? In one cell, I've made this design, and in one cell, I have made this design. Are they two different cells? No, not at all. Both of them are referred to as the Anish-Cow cells. Both of them are referred to as the Anish-Cow cells. Then why have I drawn two different designs for them? Because this one over here is looking like a caterpillar. This has a caterpillar chromatin. This has a caterpillar chromatin. It's looking zigzag like a caterpillar. And this over here is totally round, means it has an owl eye appearance. It has an owl eye appearance. Are they different? No, I'll give you it's just how you look at a thing. For example, if you look at this pencil like this, you'll say it's looking like a line. It's looking like a line. The same pencil, I show it to you from this angle, you will say it's looking like a dot. Agreed? Like this, in this dimension, it was looking like a line, and in this dimension, it's going to look like a dot. Same way. When I show you the cell like this, it's looking like a caterpillar. When I show you the cell like this, in transverse, it is looking owl-eye. Are they the same cell? Of course, nothing has changed. The cell is the same, guys. It just has different appearances. Like this, it's a caterpillar. Like this, it's an owl. And do you know what is this entire thing known as? Means the fibrinoid necrosis with the Anishka cell. Now I'm going to make a big, a boundary around it, because this entire thing is referred to as an Aschoff body. So what all does an Aschoff body include? Which necrosis? Fibrinoid necrosis. Which cells? Anishka cells. Which layers? It is seen in all the layers, but where is it maximum? Myocardium. And this is the most characteristic lesion, that is Aschoff bodies.
Question number 13. A 12-year-old child presented with 15 days of cough. On examination, cervical lymphadenopathy was noted, and the lymph node biopsy showed the following features. What is the most probable diagnosis? Your options are. And the correct answer is tuberculosis. Here's the explanation.
With the lung, if the lymph nodes are also affected, then it becomes a complex. With the lung, if the lymph node is also going to be affected, then it becomes a complex. Next, what is Ranke's complex? In this, if Ranke calcification occurs, that becomes Ranke's complex. So simple. What did I tell you first? Gone focus is just one focus in the lung. If along with that the lymph node is also affected, that becomes a gone complex. Complex matlab bahut sara. Complex are two things, lymph node and lung. And finally, if calcium gets deposited in these places, radiologist is telling you calcification, then you talk about Ranke's complex. Three things are done. Gone focus, gone complex, Ranke complex ho gaya.
Question number 14. An elderly male smoker presents with a chronic cough, significant weight loss, and fatigue. The serum calcium level is raised. A lung biopsy was done, and it showed large atypical cells with hyperchromasia. What is the probable diagnosis? Your options are. And the correct answer is squamous cell carcinoma. Here's the explanation.
Adenocarcinoma can never happen in a smoker. It can happen in a smoker. That also doesn't mean that squamous cell carcinoma can't happen peripheral. No, there are all possibilities present in medicine. What I'm teaching you is the most common agenda or the most common way of learning it. But everything is possible when it comes to lung tumors. So now, out of all these cancers, your next question would be, tell me something about the genetics and how did they form. So first I'll tell you what are the genetic alterations. Then I'll tell you how first pre-cancer occurred and then cancer occurred. So when I talk about the genetics, some of the genetics you have studied if you have studied your chapter of neoplasia well, which I know you don't like too much. No one likes neoplasia too much, let's be honest. But yeah, we can't escape it. Coming back to the genetics, when I'm talking about squamous cell carcinoma, remember there is either a loss of chromosome 3 or a loss of chromosome 17p. What is on chromosome 17p? Again asking you from neoplasia. On chromosome 17p, we have a very important policeman, that is P53. The policeman is a problematic gene, that is P53 gene is problematic. Obviously, if policeman is going to be a problem, then of course I'm going to have a cancer. Coming to the next, talking about adenocarcinoma. When I'm talking about adenocarcinoma, all of these things you have studied, and I will remind you, all of these things you have studied. What all have I written? There is a gain of function of EGFR, of ALK. Can you dissect it with me? What is itis? Itis matlab inflammation. Everyone knows. What is thrombo? Thrombo means blood clot. So simple. Itis means inflammation and thrombo means blood clot. So there is inflammation and thrombus where? They are saying in the phlebo. Phlebo means veins. So the veins are going to show me inflammation and thrombus formation. But that phenomenon is migratory. When I say avara or migratory, that basically means it's roaming from first it's in the veins of the left hand, then it will come to the veins of the right hand, then it can go to the leg. So it's roaming around in the body. So remember that the inflammation and the blood clot that is affecting the phlebo, the veins, that is roaming around in the body, avara, roaming around avara. So avara is going to be adenocarcinoma. Simple. Squamous has K sound, so calcemia. Adeno is avara, so it is migratory. And please remember, this migratory thrombophlebitis in surgery is very famously known as the Trauzius phenomenon. Very important question, right? And which other cancer? Let me ask you a little bit of surgery here. Which other cancer can show you the Trauzius phenomenon? It is going to be the pancreatic cancer, even pancreatic. So remember, two cancers which show you the Trauzius phenomenon, which show you migratory thrombophlebitis. Very, very important question. Migratory thrombophlebitis is going to be shown by lung adeno. One of them is going to be lung adenocarcinoma. Other one is going to be pancreatic adenocarcinoma. Again, when you go back to your surgery classes, you will find this information very, very useful. Coming back, now comes the one that sounds small but is never ever small. It's always got lengthy lists. So first and foremost, SIADH. SIADH is going to be syndrome of inappropriate ADH secretion. Okay. Next is Cushing's disease. It is going to have Cushing's disease. It is associated with Lambert-Eaton syndrome. It is associated with Lambert-Eaton syndrome. So can you see a very long list coming up over here? But if they ask you which is the most common paraneoplastic syndrome out of these, SIADH is the most common. Out of this entire list, SIADH is the most common. So what did you realize? You will say, whenever you are talking about this small cell carcinoma, ma'am, you are giving me such lengthy. First you said that it is small, but after that you started giving me lengthiest lists. When it came to paraneoplastic syndrome, you gave me a long list. When it came to the IHC markers, you gave me a long list. When it came to the microscopy, you gave me such a long list. Everything for the small cell carcinoma, you're making it very, very lengthy, because I famously call it as something. What is that? Chota packet, bada dhamaka. That is what I call it. It sounds small, chota packet, but bada dhamaka. Everywhere, look at the genetics. Look at the precursor lesion, so long. Look at the microscopy, the markers, the paraneoplastic syndrome. So chota packet, bada dhamaka means this is going to be the most aggressive lung cancer that we have. The most aggressive lung cancer. So always remember, chota packet, bada dhamaka. Sounds very, very chota, small, but it is going to be extremely huge in everything that you talk about. But the story is not over. Finally, the cancer that I have been conveniently ignoring, right, very nicely ignoring, large cell cancer, at least that has some paraneoplastic syndrome that you have to know, and that is known as gynecomastia. So how I have learnt it is that when I'm talking about large cell carcinoma, the large cells are also large and the breast is also large. Okay, the cells are also large and the breast is also large. So that is gynecomastia. That wraps up your entire paraneoplastic, and your main table that you had to know for the lung tumors is sorted. But little bit more information that we have to know over here. Let's start off with that so that we can complete this topic. So first and foremost, 2-3 questions will come to your mind, that lung cancer is always associated with smoking, isn't it? But when lung cancer is in non-smokers, in never ever smokers, what is the situation like that over there? Lung cancer in never smokers who have never ever smoked, what happens in them? They are usually females, although nowadays there's no male-female discrepancy when it comes to alcohol and smoking. It's equal predominantly in both.
Question number 15. The family pedigree chart is given below. Identify the mode of inheritance of this condition. Your options are, and the correct answer is autosomal dominant. Here's the explanation.
Whenever in doubt, what do? There are 7 pedigree charts. Number 1, is this mitochondrial, mother to all, father to none, mother to normal hai? So this is not mitochondrial. Is it gonadal mosaicism? One child is affected and everyone is normal? No, everyone is affected, not gonadal mosaicism. Is it only male, father to all the sons? No, I can see daughters are affected. Is it DDDD, dad to daughters, all the daughters? No, dad is giving it to sons also. So these 4 are ruled out. Now I ask you, is there a gender bias? Here a male is affected, and here females are affected. Is there any gender bias? No, there is no gender bias. What is the next G that you will look out for? Generation. So is the first generation affected? Yes. Second generation affected? Yes. Third generation affected? Yes. So all generations are affected. What is your answer? All generations means autosomal dominant. There's another easy way of picking it up. Whenever someone comes to you that with a disease, if that person has at least one parent affected. So this person has the disease, at least one of his parents is affected. This person has a disease, at least one parent has to be affected, because it's coming in every generation. So remember, one parent at least has to be affected to call it autosomal dominant.
Question number 16. In iron deficiency anemia, all of the following are increased, except. Your options are, And the correct answer is transferrin saturation. Here's the explanation.
Analyzing iron studies. Okay, so what are the different iron studies that you have to know about? Listen to me. First, you measure serum iron. You measure serum iron, measuring the levels. Next, you measure what does iron bind to? Iron binds to transferrin. So next, what you measure is transferrin saturation. What we measure next is transferrin saturation. What is the storage form of iron? Storage form of iron is ferritin. Okay. Now, there's another parameter which you call as TIBC. Please note the full form first. Total iron binding capacity. Total iron binding capacity. Okay. Right now, these are your basic things. Then I'll tell you some advanced ones also. Basic में क्या आता है? Iron, transferrin saturation, storage that is ferritin and TIBC. Think logically. You are dealing with a case of iron deficiency anemia. Do you think iron levels will be normal, lower, increased? Of course, iron deficient है तो ma'am, iron deficiency में iron levels will be low. If there is less of iron, no one will bind to transferrin. Transferrin saturation will also be low. If there is no iron, then bank account may be no savings. Nothing is going to be there. Full poor broke person, no iron, no saturation, no ferritin, no transport, no storage, nothing. Now, when you have no food in your system, and even if I give you one piece of chocolate or one toffee, you are going to like grab onto it and eat it. When you have no iron in your system, what do you think is your hunger? Total iron binding capacity. You will say, ma'am, my hunger is 100%. So the only thing that has increased is TIBC. The total iron binding capacity is a lot. So think logically. When there is no food in the body, of course, the hunger for the food is going to be very high. Total iron binding capacity is very high. Next, if I ask you, why am I always talking about iron? Because you will say, ma'am, I want to make hemoglobin. So simple concept, I need iron. Iron combines with what to make hemoglobin? Taking you into biochemistry. Iron combines with what? Iron combines with protoporphyrin. Iron combines with protoporphyrin. So think logically, when iron is only not there and hemoglobin production is going to go down, who is standing free in the system? Forever single. Protoporphyrin is forever single. Protoporphyrin says, I had to partnership with iron. My partner has not come, so I am forever single. So if they ask you, what is free erythrocyte protoporphyrin levels going to be? Repeating, if they ask you, what are the levels of free erythrocyte protoporphyrin? These are going to be increased because protoporphyrin has become forever single. Protoporphyrin says, I am forever single. There is no iron in my life. So I will now just keep waiting and I'm waiting for iron to come one day. So what did I realize? All the parameters decrease. The only two parameters that increase are going to be TIBC and FEP. Similarly, in the previous one, all the parameters were decreasing and the only parameter that was increasing was going to be RDW. That is how you learn iron deficiency ka blood parameters.
Question number 17. The lining epithelium of the respiratory tract of a middle-aged man who is a chronic smoker shows a change from columnar to stratified squamous epithelium, as depicted in the image below. The change is called, your options are. And the correct answer is metaplasia. Here's the explanation.
Epithelial to epithelial. So, if someone asks you which is the most common metaplasia that we have, and your answer is squamous metaplasia. So, your answer is going to be squamous metaplasia. So, let's understand and you'll also get to know how did I name it. So, let me take the example of the lungs. Now, tell me, what is the epithelium of the lungs which everyone is very well aware of? It is the pseudo-stratified ciliated columnar epithelium. Going back to your first year, right? Pseudo-stratified ciliated columnar epithelium. So, in other words, I have an epithelium with a lot of cilia. But what if? What if I am now dealing with a person who is a chronic smoker? Everyone knows that smoking is going to damage the epithelial lining, right? So what if someone is a chronic smoker? Point number one. What if someone is going to have vitamin A deficiency or vitamin A excess? Both are a problem. Vitamin A deficiency is also a problem. Vitamin A excess. So vitamin A has to be within normal, only then the epithelium remains normal. Less is also a problem. Excess is also a problem. You know what happens in these people? Either someone is a smoker or someone having a vitamin A problem, and this epithelium changes into squamous epithelium. So now guys, has first and foremost, has one epithelium changed into another epithelium? Yes. So do you want to call it metaplasia? Of course. But why did you call it squamous? What did this tell you? How are you doing the terminology? Based on the starting point or the ending point? I am doing the terminology based on the ending point, and that is the squamous is in the end. So as we always say in life, no matter what you do, end result matters. End mein kya hua, kya bana. So end result matters, that is squamous epithelium. So remember, whatever is going to be the end result, that is going to be the terminology. That is why I called it squamous metaplasia.
Question number 18. A 20-year-old patient presented to the clinic with a history of malabsorption, diarrhea, and poor appetite. A duodenal biopsy showed crypt hyperplasia, villi atrophy, and CD8+ cells in the lamina propria. What is the most probable diagnosis? Your options are, and the correct answer is celiac disease. Here's the explanation.
What is DDDD? So please remember, whenever the patient will consume any gluten, that is barley, rye, oat and wheat, that person will end up having diarrhea. That person will end up having intolerance. Sensitivity means person will end up having diarrhea. Point number one. Point number two, please remember, which is the intestine which is going to get damaged the most? Maximum impact. Maximum impact is on the duodenum. D for duodenum. Guys, what is absorbed from the duodenum? Socho, think. What is absorbed from the duodenum? Iron. I am saying the duodenum is gone. The duodenum is gone. Will iron get absorbed? Of course not. So this means the patient is going to have iron deficiency, IDA. Iron deficiency anemia is going to occur. Cool. Next, what is the next D that we have? So diarrhea done, duodenum done. Please remember, these patients are going to have a very important skin manifestation also, that is known as dermatitis herpetiformis. Dermatitis herpetiformis. Now, what is the correlation? Most of the students, I have realized, you are just mugging it up that, okay, yeah, there is dermatitis herpetiformis, but I want you to correlate it with your, integrated with your dermatology. What is dermatitis herpetiformis? It is a skin disorder because of IgA. And are all the antibodies that I told you right now in this disease also IgA? So imagine all the IgA forming in your intestine is going and attacking the skin also. So it's the same antibody, that is why they are seen together. And guys, in dermatology, tell me, I've added this over here. What is the treatment that we usually give for dermatitis herpetiformis? The treatment is Dapsone. Having said that, these are your 4 Ds. Please do a rapid review with me. Patient comes to you with diarrhea. Maximum impact has occurred on the duodenum. That is why which deficiency occurs? Iron deficiency occurs. The skin problem is dermatitis herpetiformis, and for the treatment you will be giving Dapsone. Out of all of these, everything that I spoke about was medicine. What is a pathologist doing? What is happening in the duodenum? Let's look at a duodenal biopsy. So here you have in front of you a duodenal biopsy. And what we follow in a duodenal biopsy is a very famous criteria, which again you have read in medicine, called the Marsh criteria. What is it? So first, guys, look at a normal intestine, because that will give you a lot of orientation. What are these structures in a normal intestine? What are these? These are all villi, right? These long finger-like are villi. And what are these round things? These are all the crypts. Yes, I hope everyone is okay with this orientation. There are villi and these round things are crypts. But I am saying, when a person has celiac disease, in celiac disease, antibodies are going to come and attack the duodenum. Attack it, finish it. Antibodies are going to come and attack it. Will the villi be left? No. So what is the first point? Can you see all the villi have become flattened out? So is there villus atrophy? Point number 1. All this is a part of the Marsh criteria. Point number 1, the villi become flat. There is villus atrophy. Imagine someone is coming. So these are, for example, these fingers of mine are the villi, and there is this antibody. So this antibody has come, has attacked. So your villi have gone. Your villi have undergone atrophy. Are you going to keep quiet? Someone has destroyed my fingers, destroyed my villi. I will also fight back. How do I fight back? I realize that these round crypts, they have suddenly become an army and they are increasing. To compensate, can I say there is a crypt hyperplasia? There is a crypt hyperplasia. So basically, if one of the villi are going off, the crypts at the bottom, they are going to increase, and overall, if one thing is decreasing, one thing is increasing, can I say the overall length or the overall thickness shall remain the same? If one thing is decreasing, one thing is increasing. So overall thickness remains the same. That is point number 3, which is often missed by the students. The overall thickness that you have is going to remain the same. So please remember, guys, the thickness of this photo, the normal one, and the thickness of this photo I have shown as the same. Why? Because if villi were going off, the crypts were increasing. Last thing is IELs, intraepithelial lymphocytes. Intraepithelial lymphocytes.
Don't forget to like and subscribe if you found the video interesting. See you in the next one.